Good morning, everybody, and welcome to Medical Grand Rounds. We'll start with just a couple announcements. Next week's speaker, we'll be hearing from Dr. Nick Bonsher, who will be giving key topics in urology for the generalist audience. And just a reminder that that is actually our last presentation of the spring season, and we will see you back in the fall in September. Please stay tuned for updates. We hope to be offering some live attendance viewership again in the fall, while still keeping our virtual viewership on Teams Live. Right now, you can watch this Teams Live event for CME credit, or you can watch a recording of the event, which is available at the same link as today's invite. I'll be monitoring the Q&A throughout the session today, so please do go ahead and post your comments and your questions. We'll be interacting with that throughout the session, and I will hold many questions until the end as time permits. And now to present today's speaker, a figure well known to many of us. We welcome Dr. Nicholas Cochler. Dr. Cochler is the Andy and Bev Hansel Endowed Chair in Applied Healthcare Ethics and the Regional Director at Providence Center for Healthcare Ethics. Dr. Cochler will transition into the role of Vice President, System Ethics Services for Providence St. Joseph Health later this year. And in his current role as chair, his roles include institutional leadership, working with the internal medicine and family medicine residencies on ethics education, and also supports ethics consultation throughout the Oregon region. As holder of the endowed chair, Dr. Cochler engages in collaborative outreach, as well as research and scholarship, representing the work of the Ethics Center in the community and in professional publications and conferences. Dr. Cochler's research interests are broad and center on the intersection of the disciplines including health sciences, philosophical ethics, theology, and anthropology. He publishes articles and presents papers in healthcare ethics regionally, nationally, and internationally. Currently, he is authoring the forthcoming 5th edition of An Introduction to Bioethics. Dr. Cochler holds an interdepartmental doctorate in healthcare ethics, as well as other graduate degrees in philosophy and biotechnology. We are so incredibly grateful for the expertise that he brings to the Providence family and community, and we're delighted to learn again from Dr. Cochler today. Thank you. I'll turn it over to you, Nick.
Thank you so much for that kind introduction, Laura, and it's a privilege to be here once again with you all. And just wanted to put a little bit of a footnote on this presentation. And as you mentioned, I am transitioning to a new role, but the title of this presentation is not by coincidence. It was actually in 2010 that I started my time here in Portland at the center, and so this is a bit of a, if you can think of a memoir and medical grand round sort of merged together, that's what you will be getting. My overall goal for this morning is to share with you how we see ethics consultation operating within Providence. It is as we see it, a professional clinical service, and one that I suspect that there may be varying levels of understanding. So overall, my goal is to shine a light on the practices and the variations of ethics consultation that you see within Providence, but also might see outside of Providence in other practice settings. So with that as a prelude, I'd like to invite you to think about what words come to mind when you think of ethics consultation. And if you're so inclined, please feel free to put these into the chat. This is a very kind of Freudian word association type of exercise. So just to get our minds into this space of an ethics consultation and ethics in clinical settings, what comes to mind? Give you all a few minutes to do that. And I want you to just hold some space for what's coming to the surface for you. You don't have to put it into the chat. I just want you to call to mind some of those things, because I do think ethics and ethics consultation is something that is a bit prone to some mythologies, and I hope to help explore that with you. Yes, messy, muddy quagmire. Those are words that I find myself often using. Great. Okay, well, as that is simmering in your mind, I'm going to pivot and invite you to think about one other question. What clinical situations do you typically associate with ethics consultation? So when you find yourself in your practice setting thinking about ethics or thinking about an ethical question, what are those clinical situations that you often sense there's an ethical, a strong ethical dimension to? And just reading through some of the answers here so far. Tough issue, controversy, professional dissonance, moral distress, slowing down, complex case, stuck, end of life issues, end of life, moral distress, you know, a whole range of things. And I'll share some of the data that we have on the types of issues and types of clinical situations that we've been typically consulted in, and hopefully that illuminates this a little bit for you. So my objectives today are quite simple, just to describe ethics consultations within Providence and in general, to identify some clinical scenarios where it may be helpful to have an ethics consult, and then to begin to understand how to frame the impact of ethics consults in health outcomes and measures. And this is a bit of a frontier area for the field of healthcare ethics, and also here in Providence, and hopefully we can work together to best understand that kind of impact. I have nothing to disclose, and something that comes to mind is bribing an ethicist is not a viable economic model. So that is something that I can gladly state. Okay. So as an entryway into understanding what clinical scenarios might benefit from an ethics consultation, I want to take a moment and just talk about what I would term the natural history of ethical issues in healthcare. And I would invite you to think about this possibility. What if there are ethical issues embedded in every clinical encounter? It is actually a perspective of mine that there are ethical issues embedded in every clinical encounter. The question is, when do they become problematic? When do they interfere with clinical decisions and the plan of care? That's what I want to explore with you today. And to help ground our discussion this morning, I'm going to be sharing a case with you. So this is a case from our consult service. And it involves a 73-year-old man who is, quote, sent to Portland in his RV from the Midwest, where his wife remains. He is hospitalized with hip pain, possible lumbar stenosis, and received a steroid injection for management of this condition and palliation. He's new to our services, so we don't have a full workup or history of him, but he does have possible vascular dementia. It does appear that he has alcohol-related dementia. He's noted to have frequent falls and appears to meet the failure to thrive description. OT says that upon discharge, he would benefit from 24-hour supervision. His ACL is on the order of 3 point X. His slums is 10. And yet he is adamant he wants to go back to his RV in his home where he believes he can care for himself. He has a daughter that's local and who reports that his walker doesn't fit in the RV. He has a son that is also local but doesn't want to be involved, and a third daughter who's back on the East Coast who we haven't really engaged yet. He's described as having low frustration tolerance, and at home it's reported he receives Meals on Wheels. There is, interestingly, an APS investigation on the daughter being investigated for financial abuse, and there is a question about guardianship per both daughters, an interest in pursuing that for him. So this confluence of factors have raised the specter of discharge and disposition. What do we do in his case? So hold that scenario, if you will, as we go forward. We hope that ethics consultation and ethics education in general helps to transform the technical skill and knowledge that you have as caregivers into professional practices and therapeutic relationships in healthcare. We hope it does this by offering a degree of prudence or prudential judgment in avoiding default decisions, a degree of integrity in decision making by managing the moral hazards of any given situation, and a sort of a peace of mind or a fully formed conscience to avoid and mitigate the effects of moral distress and avoid moral injury if at all possible. You know, going back to this case, we could say that one default decision might be, well, he doesn't have a guardian yet, and he is telling us what he wants to do, so maybe the default is he's his own decision maker and we let him go home. Alternatively, a default decision could be, well, gosh, his assessment suggests he needs a lot of help and seems to be pretty impaired. So maybe he lacks capacity and we should just turn to a surrogate decision maker like one of his daughters. But what more? What else is here that we need to unearth and unpack to better understand what's going on? There are certainly a tremendous amount of moral hazards here. He's an elderly man who does have significant and multiple medical conditions that are complicating his care. He has a complicated social network. He's married, but not with his wife. He's got children all across the country. Some have different interests in being involved. So all of this sort of brings to the fore a real kind of messy, if I can borrow that word, situation here on how do we think about the best course of action, the best disposition for him in the given circumstances. And finally, I would suspect that a great many of you, if you were in the shoes of the attending provider or the person writing the discharge orders, would not feel an insignificant amount of moral distress. How do we protect him from harm? Harm that we foresee is likely to occur given our commitment to patient safety at discharge. So all of this is sort of flowing together and they're not mutually exclusive. The dilemma relates to the feeling of distress and here we are. In fact, it is this kind of tension or connection rather between the domain of action, what do we do, what disposition is best for him and morally defensible, and the sense of accountability or intention. How is my integrity going to be preserved in whatever decision comes out of this? So here we have two different kinds of ethical questions. What is the right thing to do? Or what decision makes the most good and the least harm for this person? And then how do I think about my culpability for the decision at play? What am I praiseworthy for? What is blameworthy for me? So it's this sense of integrity in the exercise of my professional conscience. My suggestion is that if we leave these ethical issues untreated, this could result in patient harm, poor quality care, and the erosion of integrity or moral distress and moral injury of the person or persons involved, the moral agents, if you will, those who are making the decision as part of a shared decision-making process. So my hypothesis, my suggestion here is that it is the problematic ethical issues that cause the moral turbulence in the flow of patient care. So when we encounter that kind of turbulence, how do we get through it? How do we get back on course? How do we resolve or address the disruption of patient care to get back on the pathway to healing. Let me take a step back and talk about ways that we think about clinical ethics integration. I'm borrowing this paradigm from spiritual care and from palliative care in thinking about 3 levels of integration. The first level, what we would call primary ethics, is in the care encounter itself. It's when direct caregivers or the patients and family members themselves identify and figure out the resolution to the ethical issues. So it's within the context of that therapeutic relationship that people are empowered to address and resolve, if you will, or work through the ethical issues without the additional support of colleagues or ethics consultants. It is within the scope of their roles that they do this. The second level of clinical ethics integration is what we would call clinical ethics support. And now this is done through a variety of mechanisms, and you'll see that there's a lot of variation across the country in how this is described. Here, it could be it could range from you're appealing to the chain of command or to a trusted colleague or faculty member in figuring out what the right course of action is. In other settings, it might be you're calling the mission leader or the ethics committee member that you know and bouncing off ideas on how do I think about this, or I'm not sure what this policy says. This level of support is to clarify issues related to policy and protocol, and also answering basic questions that have an ethical connotation. The third level of ethics integration is what we would call formally an ethics consultation, a tertiary ethics level. This is when you have professionally trained ethics consultants or ethicists perform a clinical service to better the patient care or to help avoid or manage the disruptions in patient care related to ethical issues. So in this case of Mr. M, we'll call him, primary ethics would be the team itself identifying and figuring out the course of action. And that could be the multidisciplinary team meeting during rounds or during a team meeting to sort out the issues. It could also be an appeal to, a higher level of support within the unit or within the department. So in this instance, it was the teaching service who had called the issue of this disposition plan. The resident on that particular service could have reached out to a faculty member and asked, what do we do in these types of situations? Or called the ethics committee member. In this instance, they reached out to ethics. They paged the ethicist directly, and that consultation began. And I'll describe that as we go forward. You'll note the little QR code in the right-hand side of your screen. This QR code would take you to the center's SharePoint page that describes clinical ethics consultation and provides a variety of resources and materials for you to explore further. So I am fond of Mihai Csikszentmihalyi's model of flow. Now, some of you may not be familiar with his work. He's a psychologist who has studied happiness, and he's written quite extensively on this concept of flow. And essentially, this is a way of describing how people are, how they do their work, that they get into this state of flow that is highly correlated with happiness. And this particular graph is an adaptation of his understanding of flow, which is this central flowing diagram or line arrow from the lower left to the upper right. So the axes are, the vertical axis is the challenge intensity to the caregiver. So the intensity of the issues or the ethical problems. And the horizontal axis is the competency of the caregiver to address those issues. The greater the challenge and the lower the competency, the more likely you are to have an experience of anxiety. The lower the challenge and the lower the competency, you're more likely to feel a sense of apathy. If you're highly competent but are not challenged, you are likely to feel a sense of boredom. So in Csikszentmihalyi's model flow is this directionality of the sweet spot between challenge and competency that we hope we can attain. As I said, ethical issues can be, when they become problematic, can be the turbulence that interferes with that flow. So clinical ethics support could be that little extra little nudge back into the stream, if you will, of the plan of care. When there is a significant turbulence, the ethics consultation can be there to help redirect and bring us back to that flow of care. So this is the sort of the meta thinking that we have developed over the years when it comes to what is an ethics consultation, how does it fit within the clinical setting, and how is it integrated with other resources that caregivers may have to it, or bring to bear. Now, to be sure, there are other alternative models for understanding ethics consults. Pavlish and colleagues have described what lends oneself to an increased risk of what they call ethical conflict. And they describe the confluence of different circumstances or factors being interactional. So different worldviews, different value sets, and in the interaction can create that conflict. System issues like limited resources or wraparound services that just don't exist, and personal circumstances like complexity, medical complexity, family setting, home setting, social determinants of health, and so on. Our colleague to the north in Providence, Mary Homan, has also provided a really helpful model adapted from the Gelberg-Anderson behavioral model for vulnerable populations. And she relates predisposing factors, enabling factors, needs factors to health outcomes. So understanding what predisposes and lends oneself to the need for an ethics consult, and then how does that translate to the impact on, say, utilization, realization rate, length of stay, readmission rate, etc. The life cycle of a typical ethics consult. You have here the disruption, that turbulence that then is identified by the ethicist around particular issues. We perform various consult activities like reviewing the chart, interviewing the requester, participating in family meetings or team meetings. There are a variety of ethical interventions that we create, for example, creating moral space for dialogue, affirming moral sentiments, and sometimes just bearing witness to the angst of others, that listening ear. It also can be disclosing our ethical thinking and explaining why this is ethically defensible or this is not. And finally, the goal here is to connect the outcomes of our interventions and our activities to the issues that have been identified as interrupting the care of the patient. And so our hope is that we can restore that flow back to proper patient care. This is an example of some of the issues that Pavlish and colleagues have found in the frequency of encountering ethically complex situations. This is a survey of physicians, I believe in the UCLA system. You might recognize one of the co-authors' names in this document that came out in the American Journal of Bioethics, Empirical Bioethics in 2015. That's right, that's my colleague Kevin Dirksen, one of the other ethicists here at Providence, co-author on this piece. So what do we see here at Providence? Now this is data that's year to date in 2021, and this mirrors years past. So it's worth noting that there hasn't been much variation, at least in the last few recent years, around the themes that we see in our clinical consultation trends. So the most common theme that we encounter is an ambiguous decision-making mechanism. So that can range from whether the patient has capacity, who's the appropriate surrogate, how do we make decisions for someone who is incapable and lacks a surrogate. Medically disinterested patient, so this is the patient or the person who does not want to effectively or can't effectively engage in the recommended treatment plan. So how do we provide the optimal care for that person in those given circumstances? And then the third most common theme that we tend to see in our clinical services is what I would term postponed decision-making due to a variety of circumstances, be they psychosocial factors impeding the effectiveness of communication, or uncertainty derivative of the clinical circumstances. So we don't know what the patient's prognosis is, and we haven't been able to do the diagnostic workup. These types of things that can delay a decision in the care of the patient. Dissecting this a little bit further, we see that the most common issue identified is how to provide optimal care given the patient's manner of engagement. Now you'll notice on the right-hand side here, I have filtered this list of issues to those top 3 themes that I mentioned in the previous slide here. So that is the most common issue that we encounter. And to give you a sense of how this is colloquially referred to, this is the non-compliant or the non-adherent patient. I've tried very hard to avoid those terms given the connotation that they can present to patients. So this is trying to reframe the non-compliance issue away from sort of this power dynamic to, well, how do we provide the optimal care to the patient given how they engage? And how to address psychosocial factors, uncertainty derivative of social contingencies. So this is ethics jargon for, this is a complex family situation, how do we navigate it? Or there's estrangement from the children who are now back into the picture, how do we navigate that? Pay attention to these 2 highlighted issues because I'll come back to those when we talk about our case. We do have a clinical ethics screening tool, which you see the QR code link there for you. If you're thinking or wondering whether a situation would benefit from a clinical consult with an ethicist, ask yourself these 3 questions. Is it about a specific identifiable patient? Is it possible that the consult outcome will be influenced? Well, excuse me. Is it possible that the consult outcome will influence the plan of care? And is this case complex enough, necessitating a subject matter expert, the ethicist, beyond what is available to the team immediately? So turning back to our case, I mentioned that this request comes from the teaching service regarding the disposition of a patient back to his preferred disposition or home versus going to a facility, which is what was recommended. Yes, it is about a specific identifiable patient, Mr. M. The result of the consult is likely to influence the treatment decisions, in this case, particularly his disposition. And it is a complex case. There's multiple comorbidities, it's a complex family unit, and so on. As the ethicist, we can identify the theme of ambiguous ethical decision-making, specifically whether the patient demonstrates sufficient capacity to make his own decisions, and how do we provide the optimal care given the patient's manner of engagement. Now you might be wondering, I thought I saw that his slum score was 10. How can we still be wondering whether the patient demonstrates sufficient capacity? This is why it's important to get into the weeds of a particular case. The slums is in this sense a screening tool and can fluctuate. When the caregivers interviewed this patient, he was able to communicate and express his preferences. And so there became a real, there was almost discordance in the data. Upon interview, he seems to be able to understand the consequences of his choices. He's able to articulate those to us. He clearly has an orientation to independence and values being at home. So he does have risk factors for diminished capacity, but it's also ambiguous whether he lacks or is demonstrating a sufficient lack of capacity to warrant imposing on his liberty. The other point to be raised here, and it gets a little bit further down in the ethical analysis of this case, is that respecting one's autonomy is not just about capacity. There are 3 components to autonomy: someone's liberty or voluntariness, their capacity or competency to manage their affairs, and an orientation to values and interests. So respecting his autonomy is in part making sure we don't unduly interfere with his liberty, that we take to heart what his values and his interests are, and understand his degree to actively participate in that decision-making process through his, when he is capable of making his own decisions. So, what is an ethics consultation, and what do we see in terms of the prevalence of this practice within Providence and beyond? So there's the old joke is, if you ask 4 ethicists for a definition or an opinion on a subject, you're likely to get 6 to 8 opinions. So I'm offering to you 3 definitions that have been very informative to us over the past 10 years. The first is from the American Society of Bioethics. It defines ethics consultation, healthcare ethics consultation, as a set of services provided by an individual or group in response to questions from patients, families, surrogates, healthcare professionals, or other involved parties who seek to resolve uncertainty or conflict regarding value-laden concerns that emerge in healthcare. Our policy here in the Oregon region simply states that an ethics consultation is a clinical consultation with ethics to help address ethical issues or concerns that might arise in healthcare. And there's the QR code to link to that on PolicyStat. That link will only be, all these QR code links will only work if you're on a Providence network or signed in to the Providence network. We have also developed over the years a bylaws for the professional practice of clinical ethics consultation. And those bylaws define clinical ethics consultation as a patient care practice to address the ethical issues involved in a specific clinical case. The central purpose of it is to improve the process and outcomes of patient care by helping to identify, analyze, and resolve ethical problems. So where can you get an ethics consult here in Providence? In the Oregon region, you can obtain a clinical ethics consultation across the care continuum. You can obtain it in the hospitals, in the acute care setting. You can obtain it in the clinics or the ambulatory care setting, and you can obtain an ethics consultation through our home and community services. So it's across the continuum of care. How do you request an ethics consultation? You can either call or message the center or an ethicist directly. You can page us via AMCOM, or you can enter an order or a referral in Epic. If the patient is an inpatient in one of our hospitals, you can order an ethics consult just like you would order a cardiology consult. If you're in the clinic, it's an ambulatory referral to ethics that should be available in the same way that you would order a referral to any other specialty service. So the slums, I see a question here. Can someone define slums? I believe it is the St. Louis University mental status assessment, and it's a tool to measure the degree of cognitive impairment in a person at a particular time. There's a lot more to it, but that's essentially what the slums score is. It is not necessarily indicative of a capacity assessment. So those two are related, but they are distinct. What does the data tell us about who performs ethics consultations? So I'm drawing from 2 national surveys that were published by Fox and colleagues over the past 2 decades. And I'll just note that there are a number of methodological issues with these surveys. They're dependent on the best informant, who may not be the person who is in fact the best informant. And it also tends to be very acute care focused. So the survey itself doesn't really even fit how Providence has organized its ethics consultation services. So it sort of presupposes a facility-based, a hospital-based consult service. And that's not how we have organized ourselves over the years. Nevertheless, it does provide some illuminating comparisons, and so we can certainly explore the limitations of this study and its applicability, but it is what we have. So what we see, the first three rows describe who is doing the consult, and there are three major models. There's the individual consultant model, the small team model, and the ethics committee model. In 2000, Fox and colleagues found that only 9% of ethics consultation services of their respondents had an individual consultant model. Compare that to 68% had a small team model and 23% had a committee model. You'll see the trends in the 2018 column here that more respondents have identified an individual consultant model as operating within their system and fewer committee models. So more often in other practice settings, you'll see fewer ethics committees doing consult work than you would an individual or a small team. The small team model did decrease a little bit, but generally in the same ballpark as it was in 2000. In terms of what Providence has done, in 2010, when I started here, the individual consultant model was applicable for highly complex cases that were escalated up past the small team or the committee model in our hospitals, which were operating depending on where you were within our region. Now, we've centralized the consultation service, and all 8 of our hospitals operate with primarily the individual consultant model. However, in some cases, the individual ethicist will work with ethics committee members to perform or complete the process of an ethics consultation. Think about how we might work with our colleagues in Seaside or Medford, where we can't easily get there on a moment's notice, that we will partner with our colleagues who are there in person. The number of individuals hospitals have performing consults in the past year, you see that decrease from 9 to 7. At Providence, we have 2 professionally trained ethicists doing ethics consultations. Across the country, those who are fellowship or graduate have a graduate degree in ethics. Only 5% doing ethics consults in 2000 had that level of professional training. It's up a little bit to 8% in the 2018 survey. In 2010 and now in 2020, we have 100% of our staff, or 2, have a fellowship and or graduate degree professional training in ethics consultation. In terms of formal supervision as part of their professional training, only about 40% nationally have formal supervision of doing ethics consults in their training, whereas both Kevin and I have had that as part of our professional development. The financial support seen as sufficient for ethics consultations. 83% of respondents said it was sufficient in 2000. That's down significantly to about 57% in 2018. And all I can say is that per the literature that we've seen in conference presentations, based on our constellation of clinical services and programs, we are about 1 FTE below what we could be or should be. Who engages the process of consultation? So this is another interesting slide to show the trends here. Anyone directly involved in the case can request an ethics consultation. Only 95% of those surveyed in 2000 said that was true. That is up to about 100% now for nationally and at Providence. Must the attending grant permission? You'll see the trend downward to no. Must the attending be notified? Again, a significant trend downward from 76% to 56%. What's interesting about these 2 data points is that the majority of our consults in Providence are requested by attending providers. So that is, I think, a noteworthy disclaimer to these statistics. Must the patient or surrogate grant permission? You see that, again, significantly dropped from 24% to 0.2%. And must the patient or surrogate be notified? Again, this is a bit of a controversial issue in the field, but dropped from about 60% to about 25%. To give you a sense of where our volumes are compared to the national survey, I've highlighted here, this table is taken from the Fox article published in 2021. You see our small hospitals here are in the first cohort, 1 to 99 beds. Medford and Willamette Falls are in the next tier, and Providence Portland Medical Center and St. Vincent's. You see here that based on 2019 data, and I did that to avoid the potential impact of the COVID pandemic on our consultations. But you'll see that by and large, we are either at or above the national average for these hospitals of those bed sizes. With the exception of, interestingly, St. Vincent's, the 500 plus bed size, the national mean is about 74%. St. Vincent's last year had 64 inpatient consultations. I should mention that these numbers are only for acute care inpatient ethics consultations for which there was an order entered in EPIC. So this is actually a conservatively small number, and actually our actual numbers are much greater than this. So for comparison purposes, I try to be very conservative in what I was comparing. We are a non-government church-operated healthcare system, so you see how our numbers can compare to that. Based on the definition provided by Fox and colleagues, we have 4 hospitals that are minor teaching hospitals. That is, they have ACGME accredited residency programs, and you see how we compare there. So the number of case consultations performed within the last year, you see in here I did use 2020 data to show essentially that the COVID pandemic did not really impact or diminish our consult volume last year. Although if you look the month to month, we did have a dip in April when we suspended elective procedures and had lower census in our hospitals. But in any case, you see that PPMC and St. Vincent's last year are in roughly the 97th percentile compared to national, the national percentage of hospitals. And you see the spread elsewhere in our system. This is an interesting slide because it shows the growth in the number of case consultations from the 2000 to the 2018 surveys. And in the 2000 survey, they noted a linear relationship between the size of the hospital and the number of consults performed. What you see in the 2018 data is a logarithmic relationship, and the hypothesis here is that the more ethicists you have on staff, the more consultations you're going to have. Now, whether that's a causal relationship or whether that is indicative of consults that have more of a need that hasn't been met, I think is where the interesting conversation needs to go with our further analysis of these numbers. To recreate that particular slide using our data, I only had access to EPIC data back to 2013, so not exactly the date range of our published colleagues, but you see in both instances a bit of a logarithmic relationship. Now, the interesting thing, again, is St. Vincent's being the larger hospital fits kind of interestingly nicely between PPMC and Willamette Falls and Medford. But both in 2013 and in 2020, there's a bit of a logarithmic relationship, which again, we have centralized our clinical ethics consultation services. So the hypothesis of the correlation with ethicists being on staff, I think, is still affirmed with these data. If we look at the annual volumes by year in ministry, we see a general trend of growth. Now, in 2014, it is noted that we had 3 ethicists on staff, one that was embedded at St. Vincent's, one at PPMC, and one at Milwaukee. And you see, notably, that the Milwaukee and Willamette Falls case volumes increased with the introduction of that 3rd ethicist in at those sites. When Father Tui retired in 2017, we reorganized our coverage and we went to a rotation of coverage. And we also introduced quarterly site visits, which I think correlates with the increase in the number of consults in Medford. This big bump here. So look at the units. This is a bit of a messy slide, but you see generally the number of hospital units requesting ethics consultation does reflect the hospital-based numbers. It does appear that there are the top 10, there are more St. Vincent departments in the top 10 departments requesting consults, but that tells me one interpretation that I have and one hypothesis I want to test further is that ethics consultations are requested more broadly at a ministry like Prof Portland in more departments because of their size, the size of their volumes. Interestingly, that within the Portland metro area, critical care units were not a top tier department requesting ethics consultations. So back to our case, as I mentioned, the requester was a teaching service. The initial contact method was direct page. The EMR order did follow. The location was at PPMC. The clinical domains that I found were relevant included internal medicine, neurology, orthopedics, behavioral health, or substance use. It was a conventional urgency. It applied to the patient. It was complex, and the plan of care was contingent on the consult. These are the activities I did, and these are the interventions provided. So now, how do we understand the impact of ethics consultation? What does this all mean to healthcare in general? So this particular lectureship is intended to describe what is innovative or what promotes excellence in healthcare ethics. And what I would invite you to think about is the way we have understood excellence in ethics consultation is related to two key components, quality and value. Quality ethics consultations is described according to these four dimensions: the people, the processes, the structures, and the outcomes. The people pertains to, for example, the professional staffing, our credentialed status, that we meet Catholic Health Association and the American Society for Bioethics and Humanities competency recommendations, that we have processes, guidelines, and professionalism in clinical practices, hence our bylaws document. We track and analyze our consult trends, and we also have peer review of cases and engage in continuing quality improvement of our consultation practices. We also have various structures. We have the tertiary model of consultation. We have defined accountability within the organization, and I think very importantly, we have electronic health record integration. This is something that was not present or not even presumed when I started in 2010, but we advocated strongly that clinicians should be able to request an ethics consultation just like they would be able to request any other specialty consult in the normal course of clinical care. And finally, the quality outcomes of ethics consultation should promote sound ethical decision-making in alignment with our mission, should help us meet accreditation standards, for example, with the Joint Commission, with Catholic healthcare and the ethical and religious directives, and should also promote magnet status. And our documentation should be effective, sufficient, and appropriate. In terms of the value of ethics consultations, I invite us to think about three domains: the triple aim, our mission fidelity as a Catholic healthcare organization, and specifically Providence's vision and strategy. There's a lot of literature on ethics consultation in the triple aim. In particular, there's a number of studies of varying degrees of varying methodological approaches that try to look at the impact of ethics consultation on length of stay, on readmission rate, utilization, realization rate, and patient and or provider satisfaction. Mission fidelity looks at, in general, Catholic healthcare has 7 core commitments. Those core commitments are listed there in that right-hand column. And then the Providence vision and strategy. So there are three pieces to Health for a Better World. strengthen our core, be our community's health partner, and transform our future. So when we look at, for example, the length of stay impact of ethics consultation, it may be first helpful to see from 2013 to 2021, what are the typical dispositions of our ethics consultation services of patients on our, that we see in our service. And you see the majority go home or to self-care. Many of them die or are transferred to a skilled nursing facility and so on down the list. Not an insignificant number are transferred to a psychiatric facility or leave AMA, but further analysis of these is warranted. When we look at the relationship between days to consult, days from consult to discharge, and the overall length of stay, we generally see that ethics consultations are requested sort of in the middle of a patient's stay in an acute care facility. Some of the data suggest that there is a diminishing returns on the effect of consult on length of stay after you request an ethics consult after, say, the first day of admission. Now, that's problematic because you're presuming that ethics consults should shorten the length of stay, and I would submit that not always. And so we need to, and that may not even be the primary impetus of getting the ethics consult. So we have to be very cautious about connecting ethics consultation to these metrics, because we wouldn't want ethics consultations to be an arm of utilization reduction, even though there should be in aggregate a general correlation with high quality care and ethics consultation. I've highlighted the two big houses, St. Vincent's and Proud Portland here for you. And I would just submit that further analysis on this is warranted. Two of my colleagues, Mark Repenchek and Mary Holman, have looked at this in a variety of ways. Repenchek has looked at this by trying to track the variance between expected length of stay derived from a subscription database, Premier, versus what is observed. And Mary Holman has looked at this by comparing it the geometric mean length of stay for the MSDRG in ethics consultation, and noting the variance there. So more analysis is forthcoming. In this particular case, we see that, because disposition was the particular question, we had to understand the morality of various disposition options. And in this case, it was noted in that particular time that we did not have sufficient evidence that the patient was incapable of making this disposition decision. And so we didn't have the justification to impose on his liberty. Moreover, imposing care and prolonging the hospitalization was thought to be a safety risk and likely not feasible, and potentially might cause more harm, especially if his behaviors began to escalate. And thirdly, guardianship processes could occur whether he was hospitalized or not. So on balance, it was felt to be, his disposition home was felt to be relatively unsafe, and was allowed to do so. In terms of our mission fidelity impact, one of the core commitments is promote and defend human dignity. These are the three of the many indicators. Do we train our caregivers to identify and respond to ethical concerns? Again, primary ethics. We have a whole arm of our center that is devoted to educational programming. Do you have and promote ethics consultation for patients and families or for caregivers? The answer to both of those is yes. In terms of our vision and strategy within Providence, ethics consultation seeks to, in terms of under the rubric of strengthening our core areas of services, ethics consultation enables and empowers caregivers and leaders to address ethical issues within their scope. It is available across the continuum of care to reflect the integration of the delivery system across that continuum. And ethics consultation promotes respectful, inclusive, and equitable care for patients and caregivers from diverse communities. In conclusion, I want to just share a little bit of a quote with you from Pope Francis, because I think it really captures this intersection of professional practice and what we try to do in ethics consultation under this sense of accompaniment. There is no shortage of men and women of goodwill, scholars included, with differing approaches to religion and with a variety of anthropological and ethical visions, who are agreed on the need to propose a more authentic wisdom about life in view of the common good. Open and fruitful dialogue can and must be pursued between all those committed to seeking meaningful foundations for human existence. The responsible accompaniment of human life from conception to natural death involves discernment and understanding born of love. It is a task for men and women who are free and dedicated, a task for shepherds, not hirelings. It's been a privilege to be with you this morning, and it's been an honor to serve you as ethicist for the past 10 years. Thank you, and I look forward to your questions.
Great. Many thanks, Dr. Cockler, for your thoughts and some really fascinating data regarding the work of our ethics program. As I wait for additional comments and questions to filter in, I have one very specific question here. Could you comment or have data on home and community care annual volumes?
If I can go back maybe to that slide, it has been generally a fraction of our service. Mm-hmm. Let's see. Well, so this is our consultation service dashboard, and if I look at home and community care, we see that year to date, there's been about 3 that we've recorded. I think that's a little underrepresented. But you know, I would say over the course of the year, we've been, I would estimate on the order of 5 to 10 consults for our home and community care. Now, I think that has been in recent years, it's been the fastest growing area of consultation. So I've noticed a significant trend in the bump in the numbers for home and community care. And we also just, they just organized their own home services ethics committee to help bring in a more proactive or preventative posture to addressing ethical questions. So I think that's going to be interesting to see what the trend does, you know, because as you do more preventative work, the numbers might actually go down, and that's okay. So yeah, so we'll see what those numbers are.
Great, thanks so much. An excellent example of engagement in the community. Another question related to volumes, I think specifically referring, just seeing kind of the difference between St. Vincent and Prague Portland. Could differences between hospitals also have to do with different patient populations? For example, do we get more socially complex cases with an increasing need for ethics support at Prague Portland because of income disparity, drug issues, etc., that you may see more at that specific hospital location?
That is a question I want to ask and go into our data to better understand. I can't speak from a data standpoint yet, but my hypothesis is there's something to that intuition that there's a difference in the patient populations served by those 2 ministries. It does seem that there are more behavioral health or patients at Prague Portland on our consult service that have behavioral health comorbidities. Whether it's a statistically significant difference, I don't know yet, but I do suspect that there's something there.
Mm-hmm. Great, thank you. Again, waiting for any additional questions to come in. I'll go back to the useful and fascinating diagram provided with regard to flow, really interesting concept and a visual that I think helped me out. It's a little bit interesting to think about our own ability to identify when we may or may not be in the stream. I wondered if you have particular thoughts on whether providers tend to perhaps over or under consult our ethics colleagues?
Yeah, that's a good question. And I don't think we adequately understand the interior phenomenon of where caregivers are. So there's different ways we can slice the question, right? If the hypothesis is that the more competent you are, the more experience you have, the less distress or anxiety you may experience in the provision of care, that might argue for more consults coming earlier in one's career versus later. But I don't know if we have the data to sort of affirm that hypothesis or not. It also kind of depends on how much exposure caregivers have or providers have to ethics, ethics education, ethics consultation in their training. And so I think, given the very varied approaches to ethics education in medical school and residency, it's hard to necessarily track that. What I can say is it seems, we have an interesting set of case studies to interrogate because of our integration with MedEd. When we do noon conferences regularly, when we round and do teaching rounds and have an ethics rotation, which I think is a national distinction that we have that many, if not any other community-based hospital system has, we are exposing our residents to a lot more ethics than our peers in the healthcare world. So that could correlate with fewer ethics consults wherever their practice setting ends up being. So a lot more to unpack there, but there's something that we need to better understand the interiority of where caregivers are, where providers are when it comes to identifying ethical issues. There was a sociologist by the name of Renee Fox who back in the late 90s had asked the question, is medicine asking too much of bioethics? And her thesis, I believe, was it's in a sense farming out ethical sensitivity and ethical competencies that should be part of the practice of medicine. And so and she used psychology as the historical case in point in the 60s and 70s when medical schools began to teach psychology and psychiatric curricula in their schools. What was happening to medicine when it was putting behavioral health issues onto the shoulders of others? So there's more to understand here for sure.
Great, really fascinating comments there, and we may have one final question that pertains to some of that perspective of Dr. Fox. I want to be respectful of our time. It is 9:02. I'm going to just give one brief comment and then leave with a final question for those who are able to stay. So just a comment from one of our listeners commenting that a person with the ACL score of the specific patient concerns about their driving and really should be notifying the DMV. And then finally, Dr. Cockler, you make the point of an ethics consult often provides an opportunity to hold space for many of the providers involved. And this question specifically asks, can you talk a little bit about burnout among ethicists nationally, and what are your personal approaches in this space?
That's a really important question, and one that I've taken to heart here. I'll put it in these terms. In our work, and particularly in ethics consultation, we engage a very skewed patient population. We are called into situations where, sort of by definition, things aren't right, or there's, high stakes, high emotional dynamics, and the risk for vicarious trauma, or secondary traumatic stress, I think is significant in our field. We at the Ethics Center have promoted, have emphasized self-care as a key component to our professional practice. So without taking space and time for ourselves to recharge our batteries, to cultivate that resiliency, I think we are at significant risk for burnout. Unfortunately, this is a dark secret, and I don't think that people have had the courage yet to shine a light on it. But I do think that I'll say anecdotally, I do think that there is a propensity for mental health issues, substance use issues within our field that I don't know if we've adequately wrestled with. And so in terms of institutional justice, in terms of cultivating resiliency and self-care, it's all part of what we need to do in order to stay engaged in this work.
Absolutely. Well, thank you so much for your talk, Dr. Cochler, and particularly for the work of the Ethics Center and the broader work among the Providence St. Joseph system. Thanks very much.
Thank you. Be well.